Good afternoon. Thank you for joining us. Today we have Dr. Sarah Healy. She's a pediatric infectious disease specialist, and she's going to be talking more about medical care of patients with gender dysphoria, and specifically the PrEP for prevention of infectious diseases.
Thanks, Kathy. Again, I'm Sarah. So Kathy had asked me if I would do some review of HIV and sexually transmitted diseases or infections in the transgender population. So kind of want to review through what to do in terms of screening, what available care is provided, what prophylaxis care can be provided, and kind of go through some of the more sensitivities associated with transgender care and infections. So as discussed at the last pediatric echo, transgender care, there's about 0.7% of American youth from 13 to 17 years of age identify as transgender. Kathy had gone through in detail about the higher prevalence of mental health problems, specifically depression, anxiety, somatization, and suicide attempts. Also high rates of alcohol and drug abuse, but I really want to point out the burden of HIV infection is quite high in this population as well. It's 3 times the national average for new HIV diagnoses. This is occurring in the transgender population, and about 22 to 28% of transgender women are HIV positive. I think the more striking number of that is that 50% of Black transgender women are HIV positive. On the right side, you can see that the breakdown of HIV diagnoses among transgender population in 2009 through 2014 based on race and ethnicity, and really you see the disproportionately affecting African American or Black transgender men and transgender women. Also, you'll see that this is very geographically specific as well. That might be related to the race and ethnicity, where 50% of those diagnosed with HIV and transgender population are in the South. A lot of the focus is going to be on the transgender women. They have the higher rates of HIV positivity, and so we'll talk quite often about their targeted screenings and treatments and access to care. So what are some barriers in care for transgender individuals? Accessing specialized care, because they believe a lot of the providers just don't have transgender knowledge or expertise and don't know how to actually speak to them about their care, and are not concerned about specific concerns they have about their care. Interestingly, in one of the studies, they looked at how much education medical students get in terms of LGBT and health issues, and not even specific to transgender individuals. And in their entire medical training, they get about 5 hours at most. There are also barriers in terms of mental health and drug and alcohol abuse and housing instability, how to identify a provider, how to keep that provider, and how to have continuity of care. And then also, where does HIV treatment and sexually transmitted disease healthcare prioritize in an individual's concerns for their transgender care? They did a survey about the top 5 health concerns of transgender individuals, and really HIV falls pretty low on that list of what their priorities are. Gender affirming and non-discriminatory healthcare was number 1. Hormone therapy and side effects was number 2 in the concerns for the transgender individuals. And a lot of individuals have concerns about how do these HIV medications, whether they be for treatment or for prophylaxis or post-exposure prophylaxis, how do they interact with their hormonal therapy is a big concern. And often they find a lot of providers are not confident in giving them correct information about this interaction, or if there is an interaction. Third is mental health care, including trauma recovery, personal care, and then at number 5 finally comes in antiretroviral therapy and side effects. So also transgender individuals are not fully engaged in their medical care, and we'll talk specifically for myself in regards to adolescents in the pediatric population. how they integrate into healthcare and how do they access care when you think of adolescents already who have limited access to healthcare, and now they have concerns that are tenfold, 100-fold on top of a normal adolescent. How are they going to access care and remain in care? So how do I usually address HIV prevention for the transgender individuals I've seen? Mostly is talking about universal HIV screening, talk about the risk reduction, talk about post-exposure prophylaxis versus pre-exposure prophylaxis, which we'll go through in detail, how to engage into HIV care, especially if they're in a transient type situation where they might not be living with their parents anymore, they might be living on the streets, where they have mental health issues. How can we maintain them engaged in care? And then also to screen and treat for sexually transmitted infections. So universal HIV screening, I'd like to remind everyone that it's recommended by the CDC based on your risk, how frequently you get screened, but everyone once in their lifetime should have an HIV test completed. If you have increased risk, and this can be as easy as saying you've just changed your sexual partner in the last year, you should have yearly screening for HIV. And then high risk is really where our transgender women are going to fall in, and some of our other transgender individuals. If they're having high risk activities, they recommend HIV screening every 3 to 6 months. So what are your activities that increase you for a chance of acquiring HIV? Men who have sex with men, if you've had sex, including anal or vaginal, with an HIV positive partner, if you've had more than one sex partner since your last HIV test, injection drug users, sex workers or individuals that exchange sex for drugs or money. If you've been diagnosed with another STD recently, you should also be screened for HIV if you weren't screened for HIV at the same time. If you've been diagnosed for hepatitis or tuberculosis, looking at your social risk factors associated with that. And then if you've had sex with anyone who can answer yes to anything above. So it's pretty broad and who to include, and I feel like we often don't ask this amount of details of our adolescents. Often this is due to time. They're within the clinic. They don't access care as frequently as our younger children. And you have to get the parents out of the room, and it could prolong your visit to move along. But these are pretty important, and if you don't ask, you don't know. And so then you don't know when you need to screen. So testing, just quickly on what type of testing is available. There are 3 specific types of testing I wanted to review. So there's the HIV antibody assay, which only tests for antibodies. These are going to be most of your rapid diagnostic tests. They're quick, they're easy to use. Some of them only require saliva. Some are a finger stick. You do have to be aware that there is a window for acute HIV acquisition, that you may miss them on an HIV antibody test, and that's about 3 to 12 weeks from infection. There are some over-the-counter ones that are available for individuals to buy at Walmart or any of a convenience store, grocery stores, and they're approved by the FDA for HIV testing. That includes the Home Access HIV-1 System Kit and the OraQuick in-home HIV test. If those are positive, they will refer you to get confirmation testing with your primary provider or with the health department. But those results really go back to you. HIV antibody antigen testing is now the preferred screening test if you come into the hospital, if you come into urgent care, to ER, to your primary care provider. It's a combination of the antibody and antigen, which is the P24. They're often called combination or 4th generation tests. The window of that you can see is much narrower, and so it gives you a more reliable result without missing this window. The window is only 2 to 6 weeks. And there is a rapid test that is FDA approved. It's the Lear Determined HIV-1/2 antigen antibody combo test that would get you a result fairly quickly and not have to wait for a 24 to 48 hour turnaround, which is great for urgent cares and ERs, and also for the office visits as well, that the patient can wait to get their result back that day. Nucleic acid tests, so these are your DNA, your RNA tests, are not recommended for screening unless you have a high-risk exposure or possible exposure with early symptoms of HIV that you're afraid is within the acute window. The window is much shorter for missing is 7 to 28 days. And we'll talk about this, that accuracy can be impacted by PrEP or PEP. So this is rarely should be used for your first line screening method. It should be in very few individuals that you send a DNA or RNA test without sending an antibody antigen assay first. And then once you have a new diagnosis, it's knowing how to engage your partner services in the area, where to refer patients to get HIV care. Hope's Clinic is a great place to refer individuals to for HIV care, as they have an integrated program that can provide all the social support, mental health support, and also medical support all in one location. But also using your public health, whether that be your county or state public health services to contact in order to know where to refer patients for high quality HIV care. Discussing the sexual health history, I talked to quite a few medical students about. The most important thing is to make it as common as asking them as what medications do you take, where have you traveled recently, do you have any pets? It's just a part of the general medical history. And you should be able to go through it with the same ease and I guess staccato that you do with the rest of your history, and that it's important, that it's confidential. And the biggest thing is don't assume anything. If you get a response and you don't know exactly what that means or what that refers to, don't assume and don't be afraid to ask clarifying questions. That often, especially the teenagers, respect you when you ask them to actually explain things to you. This goes with drug history as well. I feel like I've gotten farther away from that as I've gotten older and knowing what they're referring to. And then it also gives you a way to base assessment of HIV risk based on sexual history. So oftentimes I'll ask about partners, and again, this is getting into don't assume anything. If someone's transgender male, transgender female, don't assume who their sexual partners will be. So usually I'll ask, do you have sex with men, women, or both? How many partners have you had sex with in the past 2 months, and then in the past year? And then is it possible that any of your partners in the past 12 months had sex with someone else while they were in a relationship with you? And this helps you to do the first step in assessing risk for HIV and sexually transmitted diseases. When you get to questions about practices, make sure you leave some open-ended questions. So to talk to younger people and young adults, do you really understand what your risk is for sexually transmitted diseases? By knowing what their risk is, I need to understand what type of sex are you having. Is it vaginal sex? And clarify this. What does that actually mean? And talking to teenagers as well, talking about oral sex and rectal sex, to make sure when you ask those questions, they actually know what you're asking them. And so have you had oral sex, meaning mouth on a penis or vagina, is being very direct and very open with it and making sure that what you're understanding them to say yes or no to is what they're understanding you're asking them. For condom use, if never, usually I'll ask why are they not using condoms. Sometimes it's accessibility to condoms, not wanting to buy them at the store, not talking to parents about buying them. And then if sometimes it's in what situations do they use condoms and which situations they don't. Pregnancy prevention, I talk to both men and women and girls and boys about this, because I think the boys are just as responsible in talking about how do you prevent pregnancy. And so talking to them about making sure that they're not having assumptions on the other partner about how they're preventing pregnancy, assuming that the girl is on some sort of birth control, assuming a male partner will always have a condom. I always want to talk to especially the females about having condoms available if they are sexually active, about boys carrying condoms as well or knowing where to access those. And then I'll go into details usually right after talking about condom use, about protecting yourself from STDs and HIV, and then have they ever been diagnosed with a sexually transmitted disease. Oftentimes I will name some of the sexually transmitted disease because some people won't actually know that is a sexually transmitted disease. And then if they've had any concerns that their partners have had sexually transmitted disease. And then going into other risk categories for hepatitis or HIV, such as injection drug use, exchange of money for sex, and then kind of the open-ended question, is there anything else I need to know about? Oftentimes people would get nervous or think this is too time-consuming to go through, but you can always do initial paper screening as well. But if you do a history that way where you have the adolescent or young adult fill out the information on the paper, make sure you actually go through each point in detail to make sure what they're interpreting you're asking is correct. Because oftentimes they'll only think maybe back to their most recent partner in answering the questions, and they won't go back in history. So if you ask if they're having sex with men, women, or both, they're like, well, currently I'm only having sex with women, but a year ago it was both, or the year prior it was men only. And so I often will go through it in detail and clarify as we go. So a big question that stands is for HIV prevention, if you have a high risk individual in your office, is talking about PrEP versus PEP. So PrEP is pre-exposure prophylaxis. So that means that you are making the determination prior to your activity that you're going to take a daily antiretroviral to prevent HIV acquisition. This has been FDA approved since 2012 for adults. It's actually gone down to adolescents since 2018 as FDA approved. And Truvada is the drug of choice to use for PrEP. And we'll go into a little bit more detail regarding PrEP. PEP, on the other hand, is post-exposure prophylaxis. Most frequently, you probably hear about this in terms of bloodborne pathogen type exposure, needle sticks, concerns for contamination or contaminated products used for surgery, but needle sticks are probably the most common. It's actually a 3-drug regimen, and it should be initiated within 72 hours after the exposure, and then you continue to take it for 28 days. This is a combination of 2 drugs, so the base is Truvada still, so the TDF FTC daily, and then either take an Isentress or Trivacay, or Raltegravir or Dolutegravir. The Raltegravir, just to point out, is twice daily, and so for those individuals who start on that, they do take their Truvada once a day, but the Raltegravir is required to be taken twice a day for 28 days. We'll go into detail about what screenings do you do on individuals prior to putting them on PrEP and PEP, how do you monitor them while they're on treatment, and what do you counsel them about. So PrEP, as I said previously, was approved in 2012 by the FDA for use in adults. In 2018, the FDA did approve this for high-risk adolescents, 15 to 17 years of age, with a caveat that they do need to be 77 pounds or higher for the dosing that's used. I definitely can say that off-label this is used in younger adolescents, probably down to the age of 12 or 13. The barriers to this, especially in the adolescent population and the transgender population, is the low perception of risk. It's not fully understanding what your risk is for HIV acquisition and how can I actively prevent it. Another big issue is insurance issues, which I'll try to go through as much detail as I can and provide some links for additional information if you have a patient that is looking to use PrEP. And then a big thing, especially for our adolescents and young adults, is the effectiveness of PrEP is contingent upon adherence. And so this is always an age group that we have difficulties if they feel healthy and they look healthy, how to get them to take their medication daily and adhere to the PrEP schedule. If they don't adhere to it, it's not going to be effective and can actually promote some resistance as well. Another legal aspect is about parental consent for those under the age of 18. It varies state by state. There is no jurisdiction that explicitly says that minors can't access PrEP without parental guardian consent. There are 16 jurisdictions or states that have regulations that allow minors of a particular age to independently access PrEP. So if we look at Nevada, parental consent for HIV care and PrEP, the age of the majority is 18. Adolescents can access STI diagnosis and treatment on their own, HIV testing and HIV treatment on their own, but HIV prevention does not fall under the Nevada statute. I haven't had yet to talk to an adolescent here about PrEP and access and dealing with the consent that goes into it, of whether getting parental consent or not. I don't think we have anyone on from HOPES who might have dealt with this population and accessing PrEP in regard to parental consent in order to prescribe. So Nevada falls into that category where there's not a statute that specifically says that teenagers can access PrEP or HIV prevention on their own without parental consent. It falls under the category of there's no law that says they can't. And so you can see some of the states down on the right. The ones in purple are prevention is available for STIs, and then the blue states are those with HIV services, and then the ones in green are any healthcare services that they can access on their own. So PrEP and hormonal therapy, if you remember, hormonal therapy is a big question for our transgender population. Do I really want to take PrEP, something that's preventative, it's not even treating a disease, if it's going to impact my hormones? From the studies that have been published, there have been no known interactions between common hormonal therapy and PrEP. There's no clinically significant interaction specifically with the Truvada and some of the lower level hormones using contraceptives. In women was the first study that was conducted. And then they looked at it and transition-related care in transgender populations specifically, that there is no affecting on their hormone levels as well. And so it is able to provide some reassurance to your transgender population that PrEP should not impact their hormone levels. They should be able to take it safely. So in prescribing PrEP, the first thing is to see what their HIV status is prior to prescribing. So a rapid test, unless they are concerning for that window where you think you need to also get a viral load on them via DNA or RNA test. If your HIV test is positive, you're not eligible for PrEP, you should be referred to care pending confirmation testing. If it's negative or indeterminate, then you do need to assess whether they have signs and symptoms of acute HIV or very high risk activities in the preceding 4 to 8 weeks for acute HIV acquisition. If they don't, then they are HIV negative and eligible for PrEP. If they do, then you go down this pathway of how do you confirm, do you retest, when do you retest, and then when do you defer your PrEP decision, as you can see on the bottom of this flow diagram. So when prescribing and monitoring for PrEP, when you have someone who appears eligible and has high-risk activities that you would recommend, baseline testing for hepatitis B is recommended. Some centers also recommend baseline testing for hepatitis C, serum creatinine, and then pregnancy testing for those who are childbearing potential. The prescription that's provided is Truvada, TDF FTC at 200 milligrams per 300 milligrams POQ daily. While they're on Truvada, usually have a clinic visit the first month to assess side effects and adherence. And then after that, every 3 months for HIV testing and serum creatinine testing, and every 6 months for STI screening. So when discussing PrEP with your patient is discussing what is PrEP. That's a daily medication. Essentially, it's building, the example the CDC website gives is building an armor around the fighter cells in your body to keep them from becoming infected. The big thing is to discuss is about adherence. That only studies of daily dosing of this and consistent daily dosing of PrEP has shown the effectiveness. So that's how well you take your daily medication and that you don't miss doses or skip doses. Side effects, most common side effects, it's pretty well tolerated, but includes nausea or bloating, It usually improves over the course of the first few weeks. Most patients, if they're warned about this in advance, will adhere knowing that it will resolve after a couple of weeks. Those who are not notified of possible side effects sometimes will stop because it will make them feel essentially sick to their stomach, and they'll be uninformed that this will resolve over time. Much less uncommon is those of kidney function disorder, so looking at creatinine clearance, and that's why we monitor kidney function every 3 months. It usually is reversible, so it will normalize after the discontinuation of the medication. Also talking to those individuals who are on PrEP are about additional prevention. Barrier methods are still recommended, as PrEP's not going to prevent any other sexually transmitted diseases. That it's the best form of protection is the use of condoms and preventing of chlamydia, gonorrhea, and syphilis. If a patient reports the desire not to use condoms or only use it intermittently after starting PrEP, it's not a reason to withhold the medication, but you might increase the frequency you do your STD screening and provide education. And then lastly is to talk to individuals about signs of acute HIV infection, flu-like or mono-like illnesses, fever, or diarrhea, that they need to come back to the office for screening as soon as possible. They shouldn't wait till their next 3-month visit to discuss this, and to let them know that they're open to making an appointment anytime if they're concerned about this. So other barriers to PrEP, a big one is financial barriers. Insurance coverage really varies about who will cover PrEP and who won't. Most private and state Medicaid plans cover or partially cover PrEP. There are assistance programs that can help you for those who are not covered or only partially covered. And there's 2 good websites that you can go to apply through. And then where are our centers that are feel comfortable providing PrEP. And so when I went into the PrEP locator, which you can do for any area you're in and put in the zip code, the 2 places that come up are Hope's Clinic and then also Planned Parenthood for accessing PrEP. But this website's available that you can look at any area you're in and put in your zip code, and it will provide information about who your local providers are. So PEP, again, this is the post-exposure prophylaxis. Uses in high-risk populations are high-risk activities. This is contingent upon an individual knowing that this is available. So this is often for your individuals who are not interested in taking a daily medication or PrEP, that if they do have a high-risk encounter, and we'll talk a little bit also about sexual assaults, that they know that they can come and contact you via phone or contact you to come and see you in the office, but it really needs to be done within 3 days of the event to be useful. So the algorithm is that if you have the substantial risk for HIV acquisition, it's less than 72 hours. Most often the source of the patient might be unknown, if they're HIV positive or not. If they are HIV positive, the recommendation is to prescribe PEP. If it's unknown, then it's a risk assessment and discussing with your patient on a case-by-case basis what the risk is for HIV acquisition. Many of you have done this with needle sticks or other types of bloodborne pathogen exposures, and talking about what that risk of that blood exposure is in this situation, what is that risk of sexual exposure, and is it high enough that it would warrant that you would put them on medication for 28 days that have side effects associated with them. So substantial risk for HIV acquisition is looking at these exposures and with and when, and looking at your timing. If your risk is greater, if it's been greater than 73 hours since exposure, in general, PEP is usually not recommended. And then also these low risk exposures as well, it's usually not recommended either. So when do you prescribe and monitor when you're on PEP? Baseline testing is going to look similar to with PrEP. HIV baseline antibody antigen testing, so your fourth generation or combination testing, hepatitis B and hepatitis C. And then if possible, it's recommended if you can get it from the source individual. I feel for our transgender population, this is few and far between when this occurs. In general population as well, it's often few and far between when you can get the source individual information as well. You do get baseline serum creatinine and liver enzymes, and the test for baseline syphilis, gonorrhea, and chlamydia. And then they provide the prescription. They should start it within 72 hours. Again, this is the daily Truvada, and then either a twice a day raltegravir or once a day dolutegravir. And then you have them come back. Usually I have them come back in 1 to 2 weeks to make sure no side effects and things are going well. And that 4 to 6 weeks, you have them come back for repeat testing. Again, HIV, antibody antigen, STD, creatinine, and LFTs. And then at 12 weeks, I'll repeat their HIV testing, and then at 24 weeks. During this time, you really do need to counsel about preventing HIV with their partners if they're going to continue to have sexual activity with a new partner or additional partners, and talking about condom use or other barrier methods. And then also if they're IV drug users, to talk about safe injection practices. Same barriers to PEP. There are financial barriers. Insurance coverage does vary, but there are assistance programs that you can apply through. So the prescription assistance program is the first link. And then if it's in a sexual assault, you can actually go through the U.S. Department of Justice website, and individuals can qualify for partial or total reimbursement of their medication and all their actual clinical costs. So going through this website, I just quickly clicked through the map, went to Nevada, and then it provides all the contact information on how to apply to get that reimbursed if insurance won't cover it. So if you have a patient who is actually HIV positive, and talking to transgender individuals, it's talking about early antiretroviral use. And then you've probably heard this before. This is the new campaign that's going through, that undetectable equals untransmittable, which is U equals U, coming out of two significant studies where they had discordant couples, and that there was no within couple transmissions when the index partner was virally suppressed. And they did a follow-up study that showed viral suppression equals blocking transmission. So if your partner or you yourself is virally suppressed with a viral load essentially of 0, that you will not transmit it to your partner, is the campaign that is going through. And looking at treatment, the AIDS.gov website gives great updated recommendations that are then linked through the CDC website about what first-line initial treatments are in most people with HIV. These are the current 4, warranting some caveats about tolerability, toxicity profiles, hepatitis co-infections. But these 4 drug combinations specifically have no confirmed interactions between hormonal therapy and the first line. There are a lot of new drugs coming out, a lot of new combination drugs. So the best thing I can recommend if you're doing some HIV care is to get one of these printouts that show you what the drug looks like, what the combinations are. It also gives you information about whether or not they're recommended first line from the Department of Health and Human Services and the CDC. Every year it's changing quickly where there's new combinations coming out. A lot of these combinations are only once daily, which is a huge change from what it was 5 years ago, definitely from 10 or 20 years ago, where it used to be multiple doses a day and multiple pills a day. So it's a great reference to have. And a lot of people will know it either by the trade name or the generic name, and so it gives you both, and also all the acronyms that go with it. Screening for sexually transmitted disease, again, recommended by the CDC once yearly or every 3 to 6 months for high-risk populations, which would include our transgender population based on their sexual activities and partners. Gonorrhea and chlamydia, don't forget that you don't just test the urine. So this is where your history becomes important about what type of sex they're having. To talk about whether you need to screen pharyngeal and rectal as well for GC and chlamydia, hepatitis B and hepatitis C screening, syphilis screening, especially in northern Nevada and also in northern California. We're having quite a syphilis outbreak. And then other considerations not to forget is to talk about HSV, or herpes infections, bacterial vaginosis, genital and anal warts, scabies, and trich. So really to be open in your history to know what other considerations for STD screening besides GC, chlamydia, syphilis, and hepatitis that you should be looking into. And then lastly, not to forget that there are vaccines that can help prevent some of these infections. Specifically, HPV vaccine is now available, and it's recommended for males and females. For females, it's up to 26 years of age. For males, it's up to 21 years of age. Except if you are HIV infected or a man who has sex with other men, then you fall into the category where they actually recommend HPV vaccine up through 26 years of age. There are now 3 vaccines available. Most people are going with the quadrivalent or the 9-valent HPV vaccine. Also, your hepatitis vaccines, hepatitis A vaccine is recommended for men who have sex with men, IV drug use, and HIV positive. And hepatitis B vaccine, we should be getting to the generations where all our neonates were vaccinated, but there might be a few you miss if they are born in other countries and then immigrate over. And that's it.
Alrighty, we'll open it up for questions right now. So I just sent out something in the chat box. Is there an end date for PrEP, or is it safe to be on indefinitely?
So the ongoing studies, that's a great question, have been individuals being continuously on it. Now, the approval came out in 2012 from the FDA, so there is going to be some more long-term follow-up on individuals who have been on it since the start of those studies, so 2007, 2008. So we should be getting 10 years of experience of any prolonged effects. But if their risk is still there, the recommendation is to continue on PrEP.
What is the actual cost of PrEP and PEP if you don't have insurance?
Oh, that's a good question. I don't know the answer to that. Yeah, I don't know. Yeah. And
through Planned Parenthood or HOPES, is it reasonable enough that a child who doesn't want their parents to know could afford it? So I think there's services to help with the cost of it that they can apply through that would make it not cost prohibitive. The question and really is to talk to the lawyers about that at your hospital system is if a teenager comes under the age of 18 in Nevada and wants to access PrEP, can you actually prescribe it legally without parental consent? Now, the law says there's not, it doesn't specifically say you have to have it, but it doesn't specifically say it's okay not to have it. So it's in the semantics of how the law is written, and how it's not like sexually transmitted disease access care, where Nevada law says yes, teenagers can access that without parental consent and can get treated for that without their parents knowing. The other issue comes up is if a teenager wants to come and they want to try to apply through insurance, then their parents are going to find out about it. So it is having teenagers come, and they're not going to want to go under their parents' insurance, and they are going to have to probably go through one of these programs. I know HOPES, their pharmacy is able to get different type of deals with the pharmaceutical companies to get drugs at lower costs. And Planned Parenthood, I have a feeling, accesses the same way. What that cost is at the end, I don't know. But I could definitely ask someone from HOPES. Yeah.
Any other questions out there, please feel free to write them in that chat box or take yourself off mute.
Is there any data on HIV positivity in those under 18? And were those first statistics in adults, or is that all comers 12 and above?
So those were, the transgender one specifics were adults and adolescents, so they weren't just adolescents. I'm trying to think, I didn't come across specific rates in just the 15 to 17-year-olds in terms of transgender populations and their risk. But overall, the entire, especially transgender women, the rates were a quarter of them, and then 50% if you're African American will be infected with HIV, which is quite high.
Sure.
Anything else before we finish up for today?
If not, thank you very much for joining us.
Thank you so much, everyone.
Thank you.